Good morning. You know, a long time ago when I was thinking about what field of medicine I would go into, I decided to go into cardiology. And one of the reasons for this was because I had heard that cardiology was an evidence-based field and that cardiologists were very proud that most, if not nearly all of what they did was based on solid scientific evidence. It was based on this impression that I was very excited about entering cardiology. And indeed, over the years of my training and then cardiology practice, I really did come to believe that most of what we did was based on solid evidence. Well, this, of course, is the reason why we need to do scientific studies. A few years ago, a group of investigators actually looked at existing practice recommendations that have been put out by the American College of Cardiology and the American Heart Association, and it turned out that only 11% of recommendations were based on high-quality evidence. That's multiple randomized trials. And in fact, about half of all the recommendations that were put out were based on expert opinion only. The bad news is that in diagnostic testing and imaging, it was even worse. Maybe only about 2 to 3% of recommendations were actually based on the highest level of evidence. Now, another problem that's going on is that in the absence of evidence, the rate of imaging has gone up. These are data that came out some years ago showing that the rates of all services being offered to Medicare patients was increasing, but the biggest offender by far was imaging, which increased 70% over a period of only 7 years. Imaging rates continue to increase, although not quite at the same degree. Now, if one looks at this in more detail, one sees that most of the increase in imaging it comes from advanced imaging procedures, CT, MRI, and PET. These are data also from Medicare showing that these procedures increased fourfold over a period of 10 years. So it's not only that these procedures are increasing at such a rapid rate, but there's also a perception that we're doing a lot more of these than we really need to. And in fact, there have been comparisons between the United States and other countries. And what we find, for example, is that the United States has the highest per capita rate of doing CT scans. We do more CT scans than any other developed country. And not only do we do more CT scans, but we also pay a lot more for them. This has generated a lot of headlines in the media as well as in medical journals. And here's some examples. There's a headline from the front page of the New York Times wondering about the evidence gap for cardiac imaging. Then there's a Time magazine story which talks about a scan which could save your life. And even in an austere journal as the New England Journal, one sees a headline decrying the uncritical use of high-tech medical imaging. And all of this can be nicely summed up by a statement that Bob Bonow is one of the leaders in the development of nuclear imaging and cardiology. And this was a statement he made a number of years ago, where he said that the proliferation of imaging is under close scrutiny because as an imaging community we have failed to demonstrate added value of imaging in terms of improved outcomes or improved quality of care. Now let me tell you a national story from outside the United States. This comes from Germany. A number of years ago, they instituted a mass screening program for neuroblastoma. Now this is not imaging, this is diagnostic testing, but the lessons here are just as applicable. This is a common the most common extracranial tumor that occurs in children. It turns out this tumor leads to the secretion of metabolites in the urine. And so what they did was that in 6 states they established a mass screening program whereby urine would be collected from these children. And in the other 16 states there was no collection of urine. Now, as one might expect, the rates of diagnosis of neuroblastoma increased dramatically in those states where the screening program was implemented. And this, of course, is exactly what you would expect. In fact, it's what you would hope for. But what's interesting is that the rate of death from neuroblastoma did not change. So this is a funny finding, and we're going to look at this in a little bit more detail. How it is that one can be doing a better job of diagnosing disease and diagnosing disease at an earlier stage, and yet have no impact on the key clinical outcome. So what's the problem here? Lots of tests are being done, lots more than used to be done, and it's not at all clear that doing all these tests, especially here in this country where we're doing so many more tests than are being done elsewhere, it's not clear that doing all these tests are adding additional value. So the problem is the phenomenon of non-disease or over-diagnosis. Now, this term has been applied to screening, where one is looking at asymptomatic people, but it equally applies to people with suspected disease, where one is detecting what one thinks is more severe disease by imaging as opposed to less severe disease. So while this model has been traditionally focused on screening on asymptomatic low-risk patients, the concept is equally applicable to really all imaging tests. So this is a beautiful article that was published by Potts a number of years ago, and he presents this scenario where you have 5 patients, and 3 of them have imaging evidence of disease. Now, the top group on the top of the slide, these are people who actually undergo testing. And in this case, 3 cases of disease, all 3 cases of disease are detected. The bottom line represents people who do not undergo imaging. And in this case, only 1 of the 3 cases of disease is detected, and that happens at a later time. It happens when that person actually goes on to develop symptoms. Now, in this scenario, only 1 of the 5 patients actually dies of the disease. The other patients eventually die later of various other causes. Now let's look at this in a little bit more detail. So here's without the test. So there is actually only 1 case of real disease where the patient rate is 100%. Now among those people who don't have the diagnosis, the fatality rate is 20%, and the overall death rate for the population is 20%. So we see a fatality rate with the diagnosis of 100%, but we see an overall fatality rate of 20%. Okay, now here's with the test. We now diagnose 3 cases of disease instead of 1, so that seemingly is better. And the fatality rate among those people who have disease diagnosed is 33%, which is a lot better than 100%. And the fatality rate among those people who don't have the disease diagnosed is 0. None of these patients seem to die of disease. Yet the overall death rate from the population remains exactly the same. So this is an interesting phenomenon. More cases of disease are diagnosed. Among people who have disease diagnosed, the outcomes are better. Among people who don't have disease diagnosed, the outcomes are better. And yet the overall death rate for the population remains exactly the same. And that seems to be a paradoxical finding. And there actually is a name for this. This was described by Alvin Feinstein in a paper published in the New England Journal in 1985. He referred to this as the Will Rogers phenomenon. Will Rogers, as you see him there in the lower left-hand corner, and he talked about the Dust Bowl in which Oklahoma farmers were forced to migrate from Oklahoma to California. And he made a quip in which he said that when the Oklahoma farmers migrated from Oklahoma to California, they increased the average intelligence of both states. Now, in a way, we're doing exactly the same thing when we do imaging testing. What we're doing is we're migrating people. We're migrating people from having no disease to having some disease, or from having some disease to having severe disease. And we can see that we can engineer things to look like they're all doing better. People without disease do better, people with disease do better, and yet we have had no real impact on the natural history of disease. The overall outcome rates remain exactly the same. And this is referred to as the Will-Rogers phenomenon. Now, because of overdiagnosis. Overdiagnosis is also referred to as pseudo-disease or non-disease. And this is a situation where with an imaging test we detect disease, but this is disease that would not progress or would not cause any problems if only it were left alone. We've come to realize, in fact, that many cases of disease detected by imaging will either regress or never progress, or some other problem will catch up and actually take over. The problem with overdiagnosis is that doctors are tempted to do something about it. They're tempted to treat or to do additional procedures, and these additional treatments or procedures will not do any good, because if somebody doesn't have disease, they're going to do just fine no matter what we do to them, and yet the risk for harm is there. The other problem is that the detection of non-disease increases the denominator. It increases the pool of people whom we think have disease. And yet the overall number of people in the population who actually have a bad outcome because of the disease remains the same. And so it looks like things are getting better when they're really not. And so the phenomenon of overdiagnosis misleads us. So this leads to two vicious cycles, which are nicely illustrated here in this schematic that I got from William Black. So when more disease is being detected, there appears to be an increase in the prevalence of disease. This makes people, patients, doctors, the media, become more aware of the disease. They get a sense that this disease is a bigger and bigger problem, and that leads to a greater intensity of testing. And effectively, we have a positive feedback loop going. And then similarly, looking on the right side, we have an even more serious problem, which is that we are detecting very mild cases of disease. In fact, we're detecting cases of disease that are so mild that they won't cause any problem anyway. And so we have the Will-Rogers phenomenon that makes us all think that things are getting better, that because we have implemented these imaging studies, the outcomes are getting better. And so that then drives an increased intensity for imaging. So we have these two very powerful positive feedback loops that are working at each other, and this then drives up the amount of imaging tests that are being done. So how do we get around this? Well, a very nice thought piece was put together by Sarah Lord a number of years ago, and she pointed out this problem of extra cases. Extra cases meaning new cases of disease that we're picking up because of a more sensitive test, and yet we do not know whether or not these cases of disease are real disease or non-disease. Do these represent the same spectrum of disease that's been tested in prior trials? And so she argues that the only way that we can know whether or not we are improving clinical outcomes is by doing randomized trials. One can do randomized trials of imaging. This is an intuitive design, would be to take a target population and randomize them to get a test or not get a test, and then follow them over time. This is intuitively very simple, but this is often very hard to do because one needs enormous sample sizes to accomplish it. But this has been done. Here's an example of one such study which ran into a lot of trouble along the way. This is the National Lung Screening Trial. Patients here who were heavy smokers were randomized to CT scanning versus chest x-ray. There were a number of people who were decrying the studies that went along and tried to stop it. They considered it unethical since it seemed to be so obvious that CT was the way to go. But nonetheless, the investigators persisted, and they were able to succeed in enrolling tens of thousands of patients, over 50,000 patients. And indeed, they found that there was a reduction in mortality due to lung cancer and to all-cause mortality once the trial was over. So here's an example of an imaging study which, when subjected to the rigors of a randomized trial, did indeed lead to improved outcome. Here's one that didn't. This was a trial of SPECT imaging in patients with diabetes, but no clinical manifestations of coronary artery disease. This was a relatively small trial, but the investigators here found that despite detecting more cases of coronary disease with SPECT imaging, there was no improvement in overall outcome. Well, a number of us who have been concerned about this have called for a national conversation. And while much of the emphasis has been on radiation and radiation-induced problems coming from imaging, there's another problem, which is the performance of imaging studies in the absence of evidence. Some years ago, I had the opportunity to write a perspective piece in the New England Journal, and I pointed out this problem that a lot of imaging that's being done is being done in the absence of any evidence of benefit, and we don't know whether we're simply causing a great deal of overdiagnosis and spurring more and more imaging without improving outcomes. We've only seen a very few cases of imaging studies that have been subjected to the rigor of randomized trials that have shown benefit. We have ultrasound imaging for abdominal aortic aneurysm, mammography for suspected breast cancer, and then I just showed you the CT testing for CT imaging for lung cancer. We have many other examples of diagnostic strategies that have been subjected to randomized trials and that don't work. PSA testing, imaging for ovarian cancer. And so I have called, or many of us have called, for a national conversation in which we talk to our patients about what are the potential benefits, or do we honestly know whether there are potential benefits, and what are the potential risks, including the risks of downstream tests like I talked about in the last lecture. Let me conclude by pointing out that we're facing a very interesting phenomenon as the technology for imaging improves, becomes more and more exquisite. Better imaging, and I'm putting better here in quotes, leads to more cases of disease or more cases of seemingly severe disease being detected. And this detection of more mild disease and more non-disease represents a serious problem of overdiagnosis, which a number of people see as a major threat to our public health. And it's difficult to deal with this because the outcomes are seemingly better. It appears that among people who undergo imaging, their outcomes are better. People who don't undergo imaging, their outcomes are better. And so we're all fooled into thinking that imaging tests are leading to improved outcomes when that may not be true. And the only way to know this is by recognizing the problem and breaking these feedback loops by recognizing that prediction of events, being able to predict that somebody may get into trouble or is at higher risk of getting into trouble, is not the same thing as prevention. Just because we can assess a prognosis does not mean that by doing a diagnostic test we're actually going to improve that prognosis. And the only way that we can assess this is by doing a randomized trial. And we also must recognize that when we engage in discussions about risk, like right now we're engaged in a discussion about risk of imaging due to radiation, we also have to talk about benefits. And we also have to talk about whether or not the evidence is actually there that the imaging tests that we are implementing in practice truly lead to benefits, or whether we honestly don't know that. And if we honestly don't know that, we should admit that, we should implement that as part of our national conversation, and we should have the courage and the leadership to make the randomized trials happen so that ultimately we can give all of our patients the best quality care that they all deserve. Thank you very much.